I'm going to discuss the condition of hiatal hernias, which is a very misunderstood condition, even though most practitioners or patients have heard about this. Very few understand the more recent studies that have been done and the most recent understanding of this condition. To do that, I think we got to start with talking about how commonly we see the condition of hiatal hernias. So if you look, about 20% of the population at any one time is diagnosed with having a hiatal hernia. That's a significant number of patients. If you also dig deeper into this, you find that patients who have large hiatal hernias are seen in certain populations. For example, in morbidly obese patients, about 40% or so of patients would have a large hiatal hernia. And a hiatal hernia that's large and is usually defined as anything greater than 3 centimeters. And if you look at how many patients have large hiatal hernias, about 40% of the patients who are diagnosed have large hiatal hernias. The key is, over the years, understanding the hiatal hernia has changed. And the treatments, however, have not changed. So the point of our discussion today is to try to define what this condition is, how does it fit into the condition of reflux, and what are the options for treatment in the modern age. We're going to look at a picture. This is, if you see it behind me, and I will show this clearly in the video, this is a large hiatal hernia. You can see the diaphragm, the stomach has gone into the chest. This is a chest problem. So in this situation, this is not just a hiatal hernia that you would ignore. This is a chest disease that has to be dealt with as a chest disease. However, dealing with this conventionally has required a thoracotomy, and a thoracotomy with all the morbidity that's associated usually dissuades people from either seeking the surgery or from doctors sending their patients for surgery, because at some point the morbidity of the surgery is greater than the morbidity of the condition. This is a view of that very patient from inside. This is an endoscopic view, and you can see there is a ring, that's the hiatus, and everything past that ring is in the chest. You can imagine this kind of a situation is very difficult to deal with if you're dealing with it from a laparoscopic or an abdominal approach. So the question is, what are the apples and oranges in the world of hiatal hernias? To understand that, you have to start with a rudimentary understanding of how the gastroesophageal junction forms. So when the esophagus comes down, it will go through a hole in the diaphragm. It is not a hole, it's much more complex than a hole, but unfortunately over the years it has been seen as just an opening, and we'll discuss that. And underneath it'll join the stomach. When the esophagus joins the stomach, it's pushed into the stomach by about 2 centimeters. That forms a flap of tissue that's called the gastroesophageal valve. The gastroesophageal valve is suspended onto that hiatus. Think of a door in your house. The frame of the door is the hiatus, and the wood of the door is the valve. The frame is the key to the functioning of the door, not the wood. You can have any wood you want. If the frame is bent, it's not going to work like a door. And the same thing applies to this condition. And frankly, the body always makes similar anatomic areas. For example, if you look at how a mitral valve of the heart works, that's very similar to the way the valve of the GE junction works. In the mitral valve that people know very well, there is a ring around the valve, that's the skeleton of the heart, and you have the flap of tissue, that's the mitral valve. Think of that ring as the hiatus and the flap as the valve. In the heart, if the ring around the valve stretches, people get reflux of blood. In this case, if the valve ring stretches in the GE junction, people get reflux of the gastric contents. So the important thing is the valve of the heart, not a sphincter. The word sphincter is used based on understanding of the 1950s when we thought there was a sphincter. This is a valve. This valve works only if it is suspended on the hiatus. Any defect of the hiatus is going to make this valve not function. So what happens in this disease, and you have to look at also who gets this disease. Women get this disease usually because of pregnancies. The pressure on the diaphragm starts a process after the first pregnancy that after many years then culminates to having a hiatal defect. Men get it for two reasons. One is there are congenital abnormalities of the hiatus. This is actually one of the last things that develops in the fetus. So you can have a congenital hiatal defect, men and women. But in men, if they have a congenital defect, then heavy activity that they do, which increases abdominal pressure, will make the hiatus stretch. When the hiatus stretches for any of these reasons, because the edges of the hiatus is connected to the esophagus, it will slowly pull the esophagus out of the stomach. When it does that, the valve slowly disappears. So after a 2 centimeter hiatal hernia, you will lose the valve entirely, because 2 centimeter stretch means 2 centimeter of esophagus comes out, no more valve. That patient has esophageal or gastroesophageal reflux. Most patients are familiar with this. The important thing is that the research that has been done in the past 4 or 5 years shows that the stage of reflux is actually a very short stage in the spectrum of disease that's identified as hiatal defect syndrome. Everybody thinks about the fact that people have gastroesophageal reflux, but unfortunately, that stage where we in the past thought it could be years, and we treat it with medications, etc., that stage is short-lived. What happens is this is a process that continues, and the patient goes from stage 1, which is really just gastroesophageal reflux, to stage 2, which is an obstruction of the esophagus. People ask, when do you go from stage 1 to stage 2? The answer is when you get a hiatal hernia that's greater than 2 centimeters. Because once the hernia gets larger than 2 centimeters, the stomach starts to migrate through that hole into the chest. The abdominal pressure is higher than the chest, so the stomach is pushed up. Now, stomach is not the only thing that's pushed up. The entire retroperitoneum is pushed up through that hole into the chest. That's why it's called a sliding hiatal hernia. Sliding hiatal hernia, unlike what most people think, it's not about the thing going up and down. It's the back of the abdomen is sliding into the chest, and it carries the stomach with it. So once you are over the size of 2 centimeters, you enter stage 2. In stage 2, the patient has obstruction, because imagine taking a napkin, pulling it through a napkin ring. The esophagus is going down, the stomach is coming up, the lower esophagus gets compressed. And the larger this amount of material that comes up, or larger the hernia, the more obstruction you get. Once you have esophageal obstruction in stage 2, things are different. The important point is the patient cannot tell the difference just based on symptoms. The patient will have heartburn whether they're in stage 1 or in the stage 2. However, the cause of the heartburn is different. In stage 2, the esophagus is obstructed, so the patients will have a feeling that the food sort of lags a little at the lower esophagus before it goes down. Obviously, the larger hernia, the more the patient knows this. And people are amazing because they will find ways around this. They'll eat different things, smaller meals, etc. But when there is a slowing in transit from the esophagus to the stomach, the food that sits in the esophagus is in a milieu that's perfect for the growth of the bacteria in the food, because it's a warm, moist, dark environment in the esophagus, so the bacteria of the food start to digest the food. It's like if you left it outside. Food actually starts to spoil slowly in the distal esophagus. That actually causes the patient to get relief because the food liquefies, it'll go through this hourglass configuration. But what happens is that the bacterial liquid stays in the esophagus. It causes esophagitis. The patient reports the fact that they have heartburn. And unfortunately, if people don't understand this spectrum of disease, and the fact that the patient, once they have a hiatal hernia greater than 2 centimeters, is in stage 2 disease, they throw another pill at the patient. And the patient comes back and tells you it's not helping, because reducing acid is not going to fix esophagitis that's caused from infection. That infectious esophagitis then makes the tissues weak, fluid, and the patient will report all kinds of GI symptoms. They'll say when they lie down, they taste a bitter taste. That's actually the infected fluid coming up to their throat. They'll have coughing. That's from the stuff getting into the airway. They'll wheeze. They'll see their ENT doctor because they keep getting sinus infections. This is all the same thing. The infected esophageal liquid coming up to the aerodigestive tract. And basically, those are all what in the past have been called LPR, laryngopharyngeal reflux. That is not really acid reflux. It is reflux, but it's reflux of esophageal infected fluid. So LPR shows that the patients have a much worse condition or larger hiatal defects. So the larger hiatal defect is a syndrome. One is a GI situation. The second syndrome has to do with the patient's aerodigestive tract. They will wheeze. They will get short of breath. They may even be diagnosed as adult onset asthma, which is a non-existent situation. That asthma is an allergic response and so forth. This is not about, but their airway gets shut down because it's reactive to the infection. The other thing that happens is that the patients never even understand this part, but they slowly start getting fatigued. The cardiovascular manifestations of a larger hiatal defect are very poorly understood by people who are doing GI all day, because this is not something that they think about. But this condition affects the GI tract, the respiratory tract, and the cardiovascular system. What happens is, lots of studies have been done to show that the inferior vena cava and the left atrium get compressed by this material that has slid up into the chest. When there is compression, this is called diastolic dysfunction. So the heart is starved for blood because the blood is not able to return. So these patients will feel tired. They will get short of breath. Unfortunately, for those who are not familiar with this condition, they'll think, oh, a large hernia causes people to get short of breath because it's pressing on the lungs. It's not. There's plenty of lung tissue. It's because they have basically a low cardiac output and they get short of breath with any activity because the heart can't increase the blood flow. And then they get tachycardic. So the patient always describes feeling their heart beating in their chest. And the other thing is they get arrhythmias from compression of the atrium. So they'll get atrial tachycardias, atrial fibrillation. And one of the least understood or recognized problems is that these patients, when they get atrial tachycardias, will have clot. And they will get a stroke. And they will get a multifocal stroke from embolic clot. And very few people can think that, oh, a hiatal hernia caused a stroke. So the cardiovascular complications are very, very important for this, because the patient then thinks, I'm just getting older, that's why I can't do what I used to do and so forth. And unfortunately, this disease progresses so slowly that they don't recognize that this is really a disease. The other important aspect is a hematologic aspect, because when you get a large hiatal defect, you will get GI bleeding. They will have low hemoglobins or low crits, and no one can find the cause of bleeding because this is such a slow thing. What happens is the inside of the stomach, as it comes up through the hiatus rubs on itself, there's slow bleeding, and the many patients are treated just with iron pills or something like this, as opposed to finding the real cause. The real cause is a hiatal defect, and the treatment is to fix the hiatal defect. So the condition of hiatal hernia needs to be seen not as one thing. There are apples and oranges. The stage 1 disease is all about reflux, and it can be treated really quite well with medical therapy. Once the hiatal defect is greater than 2 centimeters, then they go into this stage 2, which is now a multifaceted disease, and it's not just a GI disease, and it's also a chest disease because everything is moved up into the chest. Now, the slide behind me, and we'll have a clearer picture with this video, shows that there are GI symptoms, there are respiratory symptoms, there are cardiovascular symptoms, and hematologic complications. These are the problems of what is called the hiatal defect syndrome. So, just like so many conditions, unfortunately, we have become very complacent with this condition of a hiatal defect. And the question would be, why have we become complacent? So many patients and practitioners experience this conversation that I'm about to tell you. The patient is diagnosed with a hiatal hernia, and the practitioner says, there's not much to do about it, we'll watch it. Well, those days are gone. And I'll explain why we have been watching these. The issue is about how you fix this problem. I just explained that this disease, once it's in the stage 2, is a chest problem. So if you are not able to go into the chest, you're not going to be able to fix this problem. And so conventional surgery for this has always been a thoracotomy. So if you look at the data for these larger, what we call giant hiatal hernias and so forth, but really that's not accurate. It's either greater than 2 or less than 2 kind of thing. The larger hiatal hernias require thoracotomy. Laparoscopic repair has failed. Everyone knows that. The data shows it, and practitioners who care for their patients are never going to send them to an operation that they know is going to fail. Objective recurrences of the hiatal defect are really, can be as high as half the time. They're complicated problems. They can have leaks in the esophagus, etc. Many times mesh is used because the hole is too complicated to fix. So laparoscopic or transabdominal approach to this problem has not been good. And it's not the surgeon who's doing it. It is the fact that the disease is in the chest and you're trying to fix it from the abdomen. And it does not, it's a technological problem rather than a technical surgical problem. So if you look in the 2000s, in the aughts, there was a landmark paper published in the Annals of Surgery where they looked at all the published literature that dealt with fixing these larger hiatal defects with laparoscopic technique. And they compared those results to patients who didn't have anything done, patients who didn't have surgery. And after they do what is called the Markov-Monte Carlo decision analytic model, they recommended that in the majority of patients, unless there's a major complication, surgery should not be done. Based on that study, which was really based on laparoscopic experience, our practitioners have been telling their patients and recommending watchful waiting as opposed to surgery, because the surgery is less successful than not doing anything. That has changed. And the thing that has changed is that we have known that fixing these patients is very successful by a thoracotomy. However, the risk of a thoracotomy compared to the benefits just does not make sense. So the thoracotomy has not been done because it's too morbid and there are complications associated with that. On the other hand, laparoscopic surgery has not been done because it is not successful, because you're really trying to put a square peg in a round hole. It's not going to work. Technology in the last 10 years, which allows us to do chest surgery through the abdomen, has changed the whole conversation. Because in this conversation, you have to go in the chest to free things up from behind the heart, from the lung, all the things I've described. This is a complex operation. Robotics has been used in two ways since its inception almost 20 years ago. One is to try to apply it to regular surgery. Let's say you're doing a gallbladder operation. Instead of laparoscopic, you do robotic. That may be a benefit, or maybe not. That is one way of doing robotic surgery. The important thing that robotics can do, which is in this case, is change how you do an operation, period. This is not another new technological advance for an operation. This is creating a new surgery. So if the robot is used to go through the abdomen, which really is tolerated very well by the patient, you go through the hiatus into the chest and do the chest operation, but the patient's body does not get a thoracotomy and doesn't even know that you were inside its chest. That is a quantum leap of change in the treatment of many conditions. There are lung cancers being done this way, everything, because a chest incision is a disease unto itself. This is a good example of how technology can change everything. So a robotic, laparoscopic, trans-diaphragmatic repair of a hiatal hernia in a functional way has been the state-of-the-art, which is an excellent choice for these patients. So to summarize this, the surgery we're talking about for patients who have a hiatal defect greater than 2 centimeters is the most cutting-edge type of an operation. The operation is a reconstructive operation. This is to be differentiated from reflux surgery like Nissen fundoplication and other fundoplications. This is not about a fundoplication. This is about taking things that don't belong in the chest, bringing them in the abdomen, untwisting things and reconstructing them, and it's like a movie going backwards to where it started. The results have been superb. The longevity of the operation, at least for as long as it's been done, is in the high 90s. And in terms of need for redo, now I told you a few minutes ago that recurrence rates and reoperation rates are around 50% with the laparoscopic. So you can see a 98% success rate is night and day difference. And the patients then have a whole different outlook on life, and their whole physiology changes. It's not just a GI change, it is a respiratory change, it is an orodigestive change, it's a cardiovascular change. The important thing about this is that as this has been done in the past few years, we're also learning that their recovery is different. These patients recover from the surgery quickly, but the recovery of these organ systems take a number of months. So if you follow these patients for about a year, the success rates that are being seen with this new surgery are, in the high 90s in terms of success rate, and it is not a success rate as judged by the physician, who tends to have rosy colored glasses, but by the patient, who not only sees the changes in their own life, but recommends this to other people. Thank you very much.